set, and then I'll start at the top of the hour. All right, Joe, you can start broadcasting.
All right, broadcasting now. Good luck, guys.
Thanks, everyone. Hi, everyone. We'll get started in just a few seconds. I see that people are logging on, so please stand by. Okay, we'll go ahead and get started now. So hello and welcome to today's session. My name is Albert Eisen Jr. and I am the Senior Program Manager of Training and Technical Assistance at the Association of Asian Pacific Community Health Organizations, or also known as AAPCHO. So on behalf of AAPCHO, I welcome you all to today's webinar titled Addressing Health Outcomes and Disparities at Native Hawaiian and Pacific Islander Serving Health Centers. Oops, sorry, way too fast. It's getting a little excited. So quickly, for those of you who are not familiar with AAPCHO, AAPCHO is an association that was formed in 1987 and currently consisting of 33 community health organizations who primarily serve the Asian American, Native Hawaiian, and other Pacific Islander populations. Our mission and goals are to really improve the health status and access to these medically underserved AA and NHPI populations. And AAPCHO is also one of the 20 Bureau of Primary Health Care funded national cooperative agreements where we are tasked with providing national training and technical assistance to health centers and other key stakeholders. We always want to acknowledge our funders at the Health Resources and Services Administration under the Department of Health and Human Services. They are really crucial in increasing access to care, improving health outcomes, and promoting health equity for all health center program grantees. We are excited today to talk about and preview the findings from our analysis of Native Hawaiian and Pacific Islander health outcomes and disparities report, which is based on the 2018 Uniform Data System. And that is the program requirement for all health centers to report annually on. And we'll talk about that more briefly in the coming slides. And this report is still pending Bureau of Primary Healthcare review. So you will get access to this report in the coming few days. So stay tuned for a follow-up email regarding this report. And for today's learning objectives, we want to accomplish 3 different goals. First is to get an overview of the 2018 Uniform Data System analysis, highlighting the impact of chronic disease outcomes for Native Hawaiian and Pacific Islander populations, especially within health centers. Second is to explore key differences between Native Hawaiian and Pacific Islander serving health centers and other health centers across the continental US, Hawaii, and the Pacific region. Then lastly, the third goal is to discuss the implications of these key findings and present opportunities to use the data for developing clinical and non-clinical interventions for your health center and your organizations. I am privileged to be joined by my 2 colleagues here at AAPCHO. First is Vivian Lee. She is our research project manager and analyst. And we also have Adam Carlito, who is our director of policy and advocacy. So thank you both for joining us. Before we go into the presentation portion of the webinar, I wanted to go through some Zoom housekeeping logistics for those of you who are not familiar with it. So on your control panel at the bottom of your screen, you'll see different features, including an audio button where you can adjust the mute and unmute. But for the sake of today's webinar, all of you will be in muted position. However, if you look at the other three options on your screen, we definitely want to engage you through the chat and Q&A function during the Q&A portion at the very end. So for the chat, you'll be able to chat to us, the host at AAPCHO, and also to your other colleagues in the virtual room. So simply click on the chat button and you'll be able to monitor kind of who's talking to who. For the Q&A here, this is a way to engage with us, the host, to make sure that your answers and your questions are answered during the webinar. And you can direct your questions to any of the speakers, including myself, Adam, or Vivian, and we'll make sure that it's addressed during or after the webinar. And as I mentioned, the chat button, you can choose to on the bottom. And then for raise hands, this is something that we're testing out often. If you are wanting to ask a question, again, please use a Q&A pod. Otherwise, the raise hand button will ping you on the side to see if there's something that you want to provide comments on during the webinar. And if you want to lower your hand, just click on that same button at the bottom. And then after this webinar, you'll get a brief survey through SurveyMonkey, so we encourage you to fill that out in case you have any feedback or comments on today's presentation. Alrighty, so we're gonna do some quick polling to engage you and the audience. It's gonna pop up on your screen in just a few seconds. All right, thank you. And so the first question, and all of the questions are populated so you can answer them all in one. The first question will ask which of the following best describes your organization type? And the options will include community health center, primary care association, national cooperative agreement, health center control network, government, academic institution, social service or community-based organization, and other. So please select the one that best describes your organization type. And then the second question that you'll be answering is, are you located in the Pacific, Hawaii, or the continental US, or other? The third question is, does your organization work with or focus on Native Hawaiian or Pacific Islanders? And those option answers are yes, no, unsure. And then the last question is, for the health centers in the virtual room, do you have new populations or growing populations of NHPIs in your city, state, or region? See that there's a lot of action in the polling right now, so thank you all for participating, and we'll keep it open for another 20 seconds just to give us a sense of who's joining us today. And I understand that we have pretty much a lot of people from across the continental US and also in Hawaii, and then our colleagues out in the Pacific may or may not be awake. So kudos to you all if you are. Give it 5 more seconds and we can share the results. Alrighty, so it looks like we have a near almost 42% who are community health centers, and a good following from government, national cooperative agreement, and PCA audience. So again, thank you all for joining, and we have also 24% from other. So thank you all for joining as well. Great representation from, again, Hawaii and the continental US as suspected, and the 2% or the 2 people from the Pacific. Thank you so much for joining us. And then for the last 2 questions, certainly great to see that most of you are working with the Native Hawaiian and Pacific Islander community, and that you are also 55% seeing growing and new populations in your local context. Thank you. And we have another polling in the later sections of our presentation, so stay tuned for that. All right, so before we hand it over to Vivian and the 2018 UDS analysis, I want to level set at this point and mention a little bit about the primary data source that we're using, which is the Uniform Data System from 2018. So the UDS is a reporting requirement from the Health Resources and Services Administration, which includes, again, the health centers, the lookalikes, and any of the Bureau of Health Workforce primary care clinics. The UDS includes socio-demographic characteristic data, It includes kind of the services that are provided, whether they're clinical or non-clinical, which we call enabling services. They also have tables that include the number of staff who are providing those services, and also some cost and financial data for those who are working more on the financial and operations side of a health center. These are reports that are released every year around the fall, and health centers are required to report and comply with these regulatory requirements each year by submitting by the February 15th deadline. So we acknowledge that a lot of you who are health centers in the room will be submitting that UDS data next month or in a couple of weeks. So good luck to you on that. And then lastly, for context, the UDS categorizes Native Hawaiians as the persons having origins to any of the original peoples of Hawaii, whereas for other Pacific Islanders, the UDS identifies those as persons having origins in any of the original peoples of Guam, Samoa, Tonga, Palau, Chuuk, Yap, Saipan, Koshrai, Ibai, Pohnpei, or other Pacific islands throughout Micronesia, Melanesia, and Polynesia. And those are available on the Bureau of Primary Healthcare website, which is the link below on the bottom of your screen. So to kick it off, I want to introduce my colleague again, Vivian Lee, who is our research analyst and project manager, who's done a really great job of analyzing the raw data set from the Bureau in the last couple of months, and she'll be going over some of the findings from those various tables that we just mentioned. So I just want to pass it on now to Vivian.
Great, thank you, Albert, for the introduction, and also thanks for the overview on the UDS data. Also, I'd like to thank all attendees for joining us on this webinar today. So in the next few slides, I will go findings on Native Hawaiian Pacific Islander or NHPI serving health centers. The reason why our report focused on NHPI serving health centers is because the NHPI population was one of the fastest growing racial groups, increasing 40% between the year 2000 and 2010. Also, according to the 2018 US Census estimates, there were roughly 1.3 million Native Hawaiians and Pacific Islanders who reside within the United States. In our analysis, NHPI serving health centers are defined as those who served greater or equal to 1,000 NHPI patients in the year 2018. NH serving health centers and PI serving health centers are defined as those who served greater or equal to 1,000 NH or PI patients in 2018, respectively. By this method, a total of 37 health centers were identified as NHPI serving health centers out of the 1,362 total national health centers. The averages you will see in the next few slides were calculated using the raw UDS data, and also to determine significance, 2 sample t-tests were conducted at significance level of 0.05. The 37 NHPI serving health centers are geographically diverse and dispersed throughout the continental US, Hawaii, and the Pacific regions. This table shows the 12 US states and territories that the NHPI serving health centers are located. According to 2017 US Census estimates, the 10 states with a significant NHPI population are Hawaii, California, Washington, Texas, Utah, Nevada, Arizona, Florida, Oregon, and New York. These 10 states overlap with the 37 NHPI serving health centers that are located in the 12 US states and territories in the table. Besides continental US, the NHPI serving health centers are also located throughout Hawaii and the Pacific, as mentioned in the previous slide. The Pacific region includes the 2 US territories of American Samoa and Guam, the Commonwealth of Northern Mariana Islands, and the 3 freely associated states of Palau, Marshall Islands, and the Federated States of Micronesia. On average, and of course as expected, NHPI serving health centers see a significantly higher percentage of NH and PI populations when compared to the National Health Center average. These average numbers translate to a 6.8% NHPI combined, 1.4% NH, and 5.4% PI patient population at the NHPI serving health centers. The 37 health centers served almost 2.5 billion patients. Of the 2.5 million patients, Of the 2.5 million patients, about 33,000 identified as NH and about 131,000 patients identified as PI. In this graph, the purple bar is the National Health Center average, green is the NHPI serving health centers, blue is the NH serving health centers, and red is the PI serving health centers. So when comparing the 37 NHPI serving health centers to National Health Center average, the former group have slightly higher percentages of patients who are limited English proficient or LEP, and low income or less than 200% of the federal poverty level. In other words, there is a marginally higher rate of patients living in poverty within NHPI serving health centers compared to the National Health Center average. Furthermore, NHPI serving health centers have higher Medicaid rates and lower uninsured rates when compared to the National Health Center average. These overall improvements in health coverage may be associated with the 2010 Affordable Care Act and the 2014 launch of Medicaid expansion and the insurance marketplace in participating states. These findings from the 2018 UDS are similar to the previous year's findings for the 2017 UDS. When looking at the NH versus PI serving health centers at individual subgroups, some pronounced differences arise and remain the same between 2017 and 2018. The first difference is that NH serving health centers have higher LEP rates than the PI serving health centers have higher LEP rates than the NH serving health centers and the national average. Another difference is that the PI serving health centers have higher Medicaid rates than the NH serving health centers and the national average. Last but not least, the NH serving health centers have lower uninsured rates than the PI serving health centers and the national average. And also, I would like to note that the number of NH serving health centers based on the definition of serving greater or equal to 1,000 NH patients, the sample is small, only 6 health centers. Again, in this graph, purple bar is the National Health Center average, green is NHPI serving health centers, dark blue is the NH serving health centers, the red is the PI serving health centers, the additional light blue bar is the Healthy People 2020 goal. So the quality of care at NHPI serving health centers do not meet the Healthy People 2020 goals except for controlled hypertension rates. When disaggregating NHPI serving health centers into 2 groups, Native Hawaiian versus PI serving health centers, the PI serving health centers appear to have better clinical quality measures, whereby their performance rates equal or exceed the National Health Center averages. More specifically, PI serving health centers were equal or better in childhood immunization, cervical cancer screening, colorectal cancer screening, and controlled hypertension. On the other hand, the NH serving health centers have worse clinical quality outcomes across the board when compared to PI serving health centers and when compared to the National Health Center averages. Despite the small sample of NH serving health centers, the analysis reveals that NH serving health centers have poorer health outcome compared to the National health center averages for childhood immunization, cervical cancer screening, colorectal cancer screening, and controlled hypertension. So according to 2018 UDS, the average number of uncontrolled diabetic patients at NHPI-serving health centers are higher than the national average. The NHPI-serving health centers have a marginally higher average rates of HbA1c greater than 9% than the national health center average. In other words, the NHPI-serving health centers have more uncontrolled diabetic patients than the national health centers. Compared to national health centers, NHPI-serving health centers also have more than double the average number of patients with diabetes, and nearly triple the average number of patients with HbA1c greater than 9%. This last graph shows diabetes and hypertension outcomes by race in health centers. Purple represents Pacific Islanders, green represents Native Hawaiians, red represents Asian Americans, and blue represents white. For diabetic patients, 38% of Native Hawaiians and 41% of Pacific Islanders served at health centers have poorly controlled diabetes, which is the HbA1c greater than 9%. For the hypertensive patients, 41% of Native Hawaiians and 38% of Pacific Islanders served at health centers have uncontrolled hypertension. When comparing uncontrolled diabetes rates across all racial ethnic groups in the graph, the data shows the PI group has the highest rate of uncontrolled diabetes, and the NH group has the third highest rate. When comparing uncontrolled hypertension across the same racial ethnic groups, the data shows the NH group has the second highest rate of uncontrolled hypertension, and the PI group has the fourth highest rate. So there were some data limitations with our analysis. First, as Albert mentioned earlier, the UDS data is health center summary data, not patient level data. So we needed to use health center averages for comparisons, and we were not able to make direct comparisons between populations for most of the measures. Second, the UDS is aggregate level data that may mask potential health and demographic differences among NHPI populations. Lastly, only 3 health outcomes, which are diabetes, hypertension, and birth weight, are disaggregated by race and ethnicity in the UDS. Therefore, we were not able to make population-wise comparisons for other important measures. So these are the findings from our report of 2018. I will hand it back to Albert now. Thank you.
Thank you so much, Vivian, and hope you all gained a little bit of information that is new to you, and wanted to do a quick knowledge check and kind of engage you all as our virtual audience using a kind of fill-in-the-blank style. So based on Vivian's findings, I wanted to see what folks learned from that section of the UDS analysis. And on your screen, you'll see a set of questions, 4 of them with fill in the blanks, and I'll just read them out loud for you all. The first one is, NHPI serving health centers are geographically diverse and dispersed across the continental US, Hawaii, and the Pacific region in blank states and territories. So the options here are numbers, so 10, 12, 20, or 50. And go ahead and select your responses. And again, there's nothing punitive about this. This is just kind of checking to see if something resonated with you all as our audience today. And for the second knowledge check question is, demographic differences are evident when blank NHPI serving health centers. So this is a verb, and the options are analyzing, aggregating, disaggregating, or stratifying. Your third question is, NHPI serving health centers have room for improvement in reaching some blank. Options for this are Healthy People 2020 goals, National Quality Forum standards, Patient-Centered Medical Home standards, or 2018 UDS clinical quality measures. So select one of those. And then the last knowledge check question is NHPIs have higher than average blank and blank numbers and rates when compared to the national average. So options for this last one are cervical cancer screening and colorectal cancer screening, diabetes and hypertension, Medicaid and uninsured, and then the fourth option is limited English proficient and low income. So yeah, test yourselves and see what pops up when I end the poll in about 30 seconds. We're getting a good 40% of you all participating in this knowledge check, so appreciate you all. And for the rest of you, you can still answer as quickly as possible, because in 10 seconds, we're gonna close the poll. Alrighty, Joe, we can go ahead and just close the poll for now. And it looks like we have a spread. And I think we have some exciting news to report that, yeah, we have pretty much a tie with 10 and 12. So 9 of you got it right. And it's 12 states and territories in the US where NHPI-serving health centers are geographically diverse and dispersed. And again, it's that table that Vivian mentioned earlier in this presentation. In terms of the second one, demographic differences are evident when it's disaggregating NHPI-serving health centers. So with the 37 health centers, our research team was able to tease out the Native Hawaiian versus Pacific Islander serving health centers based on the population thresholds of 1,000. So again, if you are an NHPI serving health center, that means you have at least 1,000 patients who are identified as Native Hawaiian. And then likewise, if you're PI serving or Pacific Islander serving health center, you have at least 1,000 patients identifying as Pacific Islander. And then for those that are NHPI serving health centers, that means you have, again, 1,000 in each, the Native Hawaiian and Pacific Islander. And that's kind of the privilege we have of looking at the raw data set that we get from the Health Resources and Service Administration is we are able to really see the differences in some of these health centers who are serving health center patients throughout the US, Hawaii, and the Pacific region. All right, last two. So it's NHPI serving health centers have room for improvement in reaching some Healthy People 2020 goals. And so again, the only goal that was reached was the uncontrolled hypertension, and the rest around colorectal cancer screening, cervical cancer screening, and the child immunization rates were not met for this 2018 EDS. All right, and then the last one is NHPIs have higher than average diabetes and hypertension numbers and rates when compared to the national average. And again, the national average being the health center average of 1,362 health centers. All right, thanks for participating in this poll, and hope we can further showcase some of the implications for this as we transition over to Adam Carlito, who will really talk about some of the recommendations and policy implications from this report. And for you all in the room, again, we want to emphasize that we need all perspectives from the policy, the research, and the programmatic side to really facilitate systems level change. And so Adam will give you a glimpse of that.
All right, thank you, Albert. As Albert mentioned, I am Adam Carlito. I'm AAPCHO's Director of Policy and Advocacy based in our Washington, DC office. Yeah, so just a quick summary of our report. The report really did analyze the 2018 UDS to highlight the impact of chronic disease outcomes for Native Hawaiians and Pacific Islanders within health centers, as Vivian laid out for us. As a result of the analysis, we're able to compare and contrast health center outcomes between Native Hawaiian and Pacific Islander serving health centers to national health centers across the United States and the US territories. In particular, our report and the data analysis demonstrates that NHPI-serving health centers are geographically diverse, with health centers spread across the continental US, in Hawaii, and the Western Pacific region. Patient demographic differences are evident when disaggregating NHPI-serving health centers into two subgroups, NH-serving versus PI-serving health centers. And quality of care at NHPI-serving health centers does not meet a majority of the Healthy People 2020 goals. And for the uncontrolled diabetes and hypertension rates are higher than average for NHPI patients, especially at NHPI-serving health centers when compared to the National Health Center average. And a few recommendations from the report. Our report findings suggests an opportunity for Native Hawaiian and Pacific Islander serving health centers to identify social determinants of health, such as income, education, and language preferences, as a means of addressing the health center or the health disparities that exist for culturally, linguistically, and socioeconomically diverse NHPI populations. In general, our recommendations include increased capacity for data and research. So by having more disaggregated data on NHPIs, health centers can better target and create more population-specific interventions that address the health and social needs of NHPIs. Beyond the UDS, national data sources may include the Center for Disease Control's National Health and Nutrition Examination Survey and Behavioral Risk Factor Surveillance System. It's also imperative for data disaggregation to differentiate between diverse Pacific Islander populations, such as Chamorros, Samoans, Marshallese, Trickies, Yappies, Palauans, and the others. Second recommendation is to explore cross-sector partnerships. Our analysis and experience demonstrate the importance of community organizations and leaders within the Native Hawaiian and Pacific Islander populations by promoting innovative community partnership models between health centers and social service organizations. NHPI-serving health centers will be better equipped to increase healthcare access and improve health outcomes for their NHPI patients. Third recommendation is to provide culturally and linguistically appropriate clinical and non-clinical services. NHPIs have unique and diverse cultural and linguistic needs that contribute to their health needs. By developing culturally and linguistically appropriate healthcare interventions, NHPI-serving health centers can effectively manage clinical quality and address the social determinants of health needs for Native Hawaiians and Pacific Islander patients. And finally, our fourth recommendation is to improve federal, state, regional, and local relationships. By engaging in government and non-governmental institutions, NHPI-serving health centers can create better policies that may result in increased funding and resources that address health disparities for NHPIs living throughout the United States and the territories. Regional partnerships are also critical to improving health outcomes for Pacific Islanders residing in US-affiliated countries in the Western Pacific who have relationship with the United States via compacts of free association. I'll explain these unique international treaties in the next slide, but federally qualified health centers in the freely associated state countries face added pressures when providing clinical and non-clinical care to their patients. As indicated in my previous slide, there are important policy challenges affecting Pacific Islanders residing in the continental US, Hawaii, and the Pacific region. As we all know, immigration status is a critical social determinant of health for Pacific Islanders, and their country of origin and place of residence play a significant role in determining health outcomes. The largest Pacific Islander populations throughout the US generally, and served by health centers specifically, are from Hawaii, the US territories of Guam, the Northern Mariana Islands, and American Samoa, and 3 freely associated countries of the Federated States of Micronesia, the Republic of the Marshall Islands, and the Republic of Palau. Pacific Islanders from Hawaii, Guam, and the Northern Mariana Islands are US citizens and are generally eligible for most federally funded health programs. US nationals from American Samoa are largely indistinguishable from US citizens, and so they're treated similarly in federal health programs. However, Pacific Islanders from the freely associated states are not US citizens, but are rather citizens of their respective countries who reside in the US as part of treaties known as the Compacts of Free Association. These nations have a special relationship with the United States that allow for mutual migration between the US and the Federated States of Micronesia, the Marshall Islands, and Palau without a need for a visa. COFA citizens are generally not eligible for federal health programs, and therefore they largely lack access to federal health benefits such as Medicaid, CHIP, and other social safety net programs. We've seen large movements of these populations across the United States, and in addition to Guam, the Northern Mariana Islands, American Samoa, and Hawaii, 9 US states have COFA populations that exceed 1,000. To further complicate Pacific Islander health disparities, there are differences on health coverage eligibility based on their jurisdiction of residence. For example, Medicaid is available in the US territories of Guam, the Northern Mariana Islands, and American Samoa. However, Medicaid in these US territories are limited. Medicaid in the territories operate as a block grant with limited federal support historically provided to the islands. But US citizens from the territories who move to one of the 50 states will have full access to Medicaid programs. Similarly, while COFA citizens are not eligible for Medicaid anywhere in the United States, some states have elected to provide health coverage through the marketplace using state funds. COFA citizens are also eligible to receive limited marketplace subsidies, but there are no marketplaces in the US territories, so these options are not available in those islands. I also want to highlight the disparity of Medicaid in the US territories versus elsewhere in the 50 states. As mentioned, Medicaid in the territories operates as a block grant with federal funding limited or capped annually, as well as the federal reimbursement rate, also known as the Federal Medical Assistance Percentage, or FMAP, statutorily set by law. This is unlike the Medicaid programs in the states where the federal government does not limit funds available to states, and state FMAPs are set by the proportion of their low-income population. This table here shows historical funding levels in the territories, as well as a recent 2-year agreement that was just enacted into law of December of last year to help the territories avoid a Medicaid fiscal cliff. As you can see in the far left column, the territory's Medicaid cap is far below their annual spending. The Affordable Care Act did provide additional resources to the territories that allowed them to spend above the cap, but that funding expired at the end of fiscal year 2019, and the new 2-year funding cap is intended to further support the territories, but Congress will again need to act at the end of fiscal year 2021, or the territories will revert back to the federal allotment, the federal cap in the far left column. Furthermore, I've already explained the lack of Medicaid eligibility for COFA citizens, but I did want to further underscore that COFA citizens used to be eligible for Medicaid and other federal benefits programs. However, as a result of the 1996 Personal Responsibility and Work Opportunity Reconciliation Act, also known as welfare reform, COFA citizens were removed from the list of eligible non-citizens who can receive benefits if they became LPRs and are in the US for more than 5 years. There has been several efforts in Congress to undo this disparity, but we've seen that additional education of members of Congress is needed to build political momentum to resolve this issue. And we're hoping that Congress will act sometime in the near future. And just some policy and future implications of our report. So our report does underscore the unique and significant health disparities experienced by Native Hawaiians and Pacific Islanders. Our analysis of the 2018 UDS highlights the impact of chronic disease outcomes for NHPI populations within health centers. The report analyzes the 2018 UDS system to highlight the impact of chronic disease outcomes for NHPI populations within health centers. our findings suggest an opportunity for Native Hawaiian serving health centers to improve immunization and screening rates by strengthening population health management strategies. The finding also suggests the potential effectiveness of Native Hawaiian serving health centers' clinical and non-clinical interventions related to hypertension, and NHPI serving health centers serving large Pacific Islander populations can increase their cultural and linguistic competency due to their higher LEP rates and lower incomes. In particular, health centers serving high proportions of Pacific Islander patients are challenged to increase access to quality care for special and vulnerable populations. And more broadly, AAPCHO does recognize that NHPI health disparities are further complicated by differing health coverage and eligibility based on an individual's immigration status and place of residence. In addition to Hawaii and the Pacific territories of American Samoa, Guam, and the Northern Mariana Islands, 9 states have Pacific Islander populations greater than 1,000, and there are varying state-sponsored programs that provide health coverage outside of Medicaid and other federal benefits programs. Native Hawaiians and Pacific Islander populations are culturally and linguistically diverse and each have unique health needs. And NHPI serving health centers are appropriately positioned to address these needs, but there is a need for additional support for them to do so. So I hope that this has been helpful in understanding some of the policy implications facing NHPIs and NHPI serving health centers. And Albert, I'll turn it back to you to wrap it up.
Thank you so much, Adam. I hope that you all were able to really get a sense of the systematic and kind of structural barriers that really complicate the healthcare access and health outcomes for the Native Hawaiian and Pacific Islander population. As Adam eloquently mentioned, again, immigration status and healthcare coverage are really important factors and determinants to influence healthcare within our Native Hawaiian and Pacific Islander community. And so I wanted to take the next 5 minutes to just review some tools and resources that AAPCHO has developed, co-developed, or really supported for health centers or stakeholders working with the NHPI population. So just wanted to start off with the, again, reminder that the report is coming very soon. And so we have set up a automated reminder for you all who have registered today to receive that full report once it's approved by our Bureau of Primary Health Care sponsors. The first resource that AAPCHO has developed for you all at health centers especially is the Enabling Services Data Collection Toolkit, which really tracks some of the non-clinical services that your health centers may be providing, such as case management, interpretation, transportation services, outreach, those that are really essential to facilitating clinical care for your health center patients. And this is meant to be a toolkit to help your staff implement. And so if you have a project manager or QI director or someone that's really able to take on a data collection initiative such as this, we encourage you to check it out, download it here, and also reach out to us at the AAPCHO Training and Technical Assistance team so that we can support your implementation. Again, this is really in the context of making sure that your health center patients are receiving the best care, both clinically and non-clinically, through your workforce. The second resource that has been co-developed with the National Association of Community Health Centers, or NAC, and the Oregon Primary Care Association is our Prepare Implementation and Action Toolkit. This is really focused on the social determinants of health data collection efforts that are happening nationwide. And this is a really comprehensive and dense, again, toolkit for you all to, again, self-implement, but you all are able to reach out to any of the key partners, including AAPCHO, for any support around how to jumpstart this data collection. And some of you might be already collecting social determinants of health data, whether it's through Prepare or some of the other screening tools out there. But one thing that makes Prepare unique is the in-language support. So we were able to translate this into multiple languages, 10 at the moment. And those 10 include the Arabic, Burmese, Korean, Portuguese, simplified or traditional Chinese, Somali, Spanish, Tagalog, and Vietnamese. And we're happy to announce that in the coming few months, we'll release another round of translations for the Prepare Screening Tool. And that includes Chuukese, Marshallese, and Tongan for some Pacific Islander communities. So that's something to look forward to. In terms of social determinants of health, again, the Bureau of Primary Health Care, through their uniform data system starting in 2019, will be asking all health center grantees to report on the types of social risk factors that your health center collects data on, and also will ask you which screening tool you use, which Prepare is one of those options. So check it out, especially as you all submit your UDS data in the coming few weeks. And in terms of the culturally and linguistically appropriate services, it's great if you can check out the Think Cultural Health website, also available made through the HHS or Health and Human Services website. Again, these are guiding principles and steps to really improve health equity, health quality, and outcomes for your racial and ethnic minority groups especially, but overall for your health center patients. And these tools are translated in some languages, as you see on the screen: Chinese, Vietnamese, Korean, Tagalog, and Spanish. And as any good kind of person from a health center, if you need things translated, definitely reach out to us at AAPCHO or your government, local, or regional institutions to see if there are opportunities to get some of these resources translated. The more they hear from us, the more they'll be enticed to do these culturally and linguistically appropriate services for the health center. And then lastly, related to some of the immigration context and issues, AAPCHO has an immigrant access to care webpage for you all to access some of the resources around, for example, public charge, eligibility for health insurance, some of the health center regulation and enforcement issues, and then some combating fears resources for those health centers, especially that are seeing decreases in patients for their usual visits or for some of their WIC SNAP benefits. We are hearing from some health centers again that there's a decrease due to some of the immigration charge issues in our current context. So now I want to take the last, again, 13 minutes to open it up for your feedback or for your questions related to any of the content presented from myself, Vivian, or Adam. You can use the Q&A pod once again on your control panel at the bottom, or feel free to chat in the chat box to any of the hosts, and we'll direct those questions appropriately. And I wanted to take this opportunity to, again, showcase the SurveyMonkey link, which my colleague Christine will put into the chat box. We always appreciate your feedback in order to improve our training opportunities. And this can include topics and content. Maybe if you want to serve as a speaker in the future, we are always looking for experts, because we acknowledge that we're only part of the presentation panel that can really talk about Native Hawaiian and Pacific Islander health issues, and we know that there are a lot more of you out there. And thank you, Christine, for putting up the link. So I'm not seeing any questions at the moment, so I take it that you all hopefully learned something new. Oh, someone asked, will the two different mentioned toolkits be available via email? Yes, we will make those links available, and I could have my colleague Christine again copy and paste those links in the chat box for you all to click directly. And if you actually quickly Google enabling services, AAPCHO, or Prepare, it should pop up in one of your Google or web searches easily at the top. But Christine, yeah, if you could help, that would be great. All right, I see one question. Oh, okay, people are just wanting resources from the website shown. So great, yeah. As part of our attendees, you all will get the follow-up email, and not just the resources that were mentioned, but the report that's going to be released once we get our final approval. And yes, someone else asked for the slide deck. You will get the slides as well. Those will be made publicly available by the end of this week, so stay tuned. We're glad that you want our resources. This is good. And again, if you have questions once you access these resources, don't hesitate to reach out to us at AAPCHO, which I'll showcase actually some of the next steps. If you want to reach out, follow up with us, have a conversation, we're always happy to, and you can do that by emailing training@apsho.org. That is our training and technical assistance teams, and we work closely with our research and policy teams to really address your various needs, so we can help triage that. We have our website for the training and technical assistance, and then there's the enabling services and Health Center Clearinghouse, which are really geared towards you folks who are working for health centers. All right, almost done here. We can end it. There are no big questions. Wanted to acknowledge some key partners who are also on the ground working with the Native Hawaiian and Pacific Islander population. That's Hawaii Primary Care Association, HPCA, the Pacific Islands Primary Care Association, or PIPCA, and then Papa Ola Lokahi. These are really close AAPCHO partners who are on the ground in the kind of the local and state regions focused on the NHPI population health issues, whereas AAPCHO, we really work more on the national level, looking at some of the federal and state legislation and how that impacts community health centers. And so you'll probably see some collaboration in the coming years with these PCAs and organizations as we continue to foster again, key partnerships across the US and our territories. Let me see if there are any more questions. None at the moment. All right, we're moving. So if you want to keep in touch with us, the speakers, here are our emails on this slide. You can also find them on AAPCHO's website if you just go to the staff, meet the staff page. Each of our contact information is there. Don't be shy. And we have a lot of different opportunities to engage with us: Facebook, Twitter, Instagram, LinkedIn, and we have a Medium blog as well if you all want to check out some of our newsletters and blogs from our various experts, both within AAPCHO and in our partnerships with other organizations. All right, so I'm just gonna keep the line and webinar open for the next, again, 8 minutes in case you all have questions, but wanted to really thank you all again for joining us, especially if you're in the Pacific. It's not usual business hours, so really appreciate your time. And for the rest of you, hope you have the great rest of your day. And if you want to provide feedback, the SurveyMonkey is now available in the chat window for you all. Thank you so much, and have a great rest of your week too.